to be able to be a part of such a group. And I really appreciate the opportunity to be here this morning and share a little bit from my perspective as well. I'm Erin Artigiani, and I am Deputy Director for the Center for Substance Use, Addiction, and Health Research, or CESAR, at the University of Maryland, so just kind of up around the Beltway a bit here. And I am here this morning because we have a program called the Emergency Department Drug Surveillance System, or EDS, and I'm going to look for the clicker here. There's two, so I'm not sure which one you pick, but hopefully my slides will come up.
It should be the skinny one on top.
There we go. All right, thank you. So I'm here representing our team at CESAR, which includes myself and a number of colleagues, some of whom I've listed here, including Dr. Erin Artigiani, who's the PI on the EDS project and was the founding director for CESAR. Okay. There we go. So I thought I'd start out by sharing a little bit about CESAR, for those of you who may not be familiar with us, and then I'm going to jump right into EDS and share some examples of some of the kinds of analyses we can do to look at what's going on with THC exposure on ED patients. So CESAR was launched in 1990, and we were launched in the wake of the sudden overdose death of a local basketball legend. He was a successful, handsome young man named Len Bias, and he had an amazing career at the University of Maryland, got drafted to the NBA, went out to celebrate, and unfortunately never made it to his first game. And after he died, it was kind of a wake-up call for the state, and they realized they didn't have a way to monitor what was going on in Maryland, to identify where the crisis was or what was causing it or how to respond to it. So the university and the state got together to create CESAR as a resource for doing just that, for monitoring trends and informing policy going forward. And since then, we've grown into an interdisciplinary research center that is focused on addressing the substance use disorder crisis, not just locally, not just in Maryland, but across the U.S. and beyond as well. And so we have projects in epidemiology, treatment, and recovery, and that includes projects that monitor drug trends in ED patients like EDS, which I'll be talking about this morning, projects designed to improve access to treatment by assessing different kinds of treatment modalities and looking for innovative approaches to reach people where they are, and then projects that are designed to provide support for long-term recovery to help people join or rejoin the local workforce and find and connect with peers and peer recovery coaches who can help them along the way. So,
ma'am, could you stand? I'm having a hard time hearing.
So the EDS system is actually located in 50 hospitals in 17 states now, and we collect two different types of data. So on the one hand, we're collecting at least twice a year de-identified limited data sets from hospital electronic health records, or EHRs, and that contains the results of any hospital urine drug tests that are conducted as part of the diagnosis or treatment of the individual, and then to supplement that information, because in many cases the hospital panels are limited in anywhere from say 8 to 12 substances, and we all know how much things have expanded. We also offer each hospital the opportunity to submit de-identified urine specimens for expanded retesting for anywhere from 200 to 500 substances by our collaborative lab. And there's a range there of the substances we test for because we like to work closely with the hospitals to make sure that we are reflecting their needs and their interests along the way. So you can learn more about our methodologies and what hospitals are participating by going to our website here. This is the homepage of the EDS system, and you'll see links there to an overview and a reports and interviews and things like that that we've done, and also a whole series of interactive data dashboards that we created for many of the hospitals participating in EDS. And so at this point, we've been doing this now for several years, and we have a really huge database of information. So we have approximately 1 million individual EHRs and more than probably 3,700 now specimens that have been retested for that expanded panel. And this enables us to look at a lot of different kinds of substances. We really cast a wide net, but today I'll be focusing in on a couple of examples of what we can pull out for marijuana or THC specifically. This map shows you where the sites are located, so you can see it really does go across the country from a hospital up in New Hampshire all the way to hospitals on the West Coast in Oregon and California. You'll see there's a couple clusters there in Florida and Maryland. That's because Florida is the hub for the healthcare system we've been collaborating with, so they have many facilities down there. And Maryland is the first state we worked with to establish a statewide system. So we have 20 hospitals in Maryland. So I'm going to start with a couple examples of what we can look at using the EHRs, and then I'll have a case study where I pull some data from one particular hospital, the expanded retesting that we did. So as I mentioned, for the EHRs, we get a variety of information, and that includes the urine test results from any testing the hospital did during the ED encounter. So basic demographic information like age, gender, race, the zip code of residence, arrival date, and disposition, and then in many cases we also get information on chief complaints and diagnoses as well. And EDS and the work we're doing with the EHR, as well as the work we're doing with the retesting, was reviewed and approved not just by the University of Maryland's IRB or Institutional Review Board, but also the IRBs of all the participating hospitals and institutions as well. And so this first example here is looking at ED patients with a drug diagnosis in 7 different hospitals. And these are people who presumably had a drug overdose. And you can see that there's 2 ways of looking at it. So the dark green bar shows the percent positive for THC, and that ranged from about 18 to 39% in these hospitals. But there's also that light green bar. That light green bar is looking at patients who were positive for THC only. So there was a clear subpopulation of patients who were coming in who were only testing positive for THC. And this again is the hospital test, and that ranged from 5 to 12%. We also, for these 22 hospitals, took a slightly broader look, and we're looking at patients who were tested who were found positive for THC or THC only in 2024. Both of these slides are actually for the first 6 months of 2024. We do have just got in the second 24 months, and we're processing that information now, so we will be releasing that through our website and our CESAR research network as well. And you can see we found the same kinds of findings here. The dark green bar showing 16 to 46% positive for THC, and again, the light green bar showing up in each hospital, showing that subpopulation positive for THC only 9 to 22%. Now, it could be that the percent there for THC only is slightly higher because we expanded the population we're looking at. So we were looking at patients positive on the hospital screen regardless of diagnosis in this case. We also have done a little case study here. This is the results of the expanded retesting for one hospital in Maryland. And in this case, we're looking at 100 hospital positive specimens. So that means specimens that tested positive for at least one drug on the hospital panel. And we then retested those specimens for 500 substances. We thought it would be interesting to look at this because this now shows you even more substances, and we still were finding that subpopulation that was positive for THC only. In this case, it was 16 patients, and the majority, 10, had at least one diagnosis related to nicotine dependence. 9 had at least one diagnosis indicating a history of mental health disorders or issues. That could be that psychosis that we heard about earlier. And a slightly smaller number, 8, had chief complaints related to symptoms that could be a part of hyperemesis syndrome, for instance, or something like that, and that included nausea, vomiting, abdominal pain, and so on. And then 6 had at least one diagnosis code related to cannabis use, but none had a diagnosis or chief complaint that was related to illicit drug overdose or poison. So, looking at all of this information, of course, a lot of questions can start coming to mind. There's a lot of other kinds of research that can be done to take a deeper dive into trying to understand these people and their backgrounds. And that is certainly work that we would be very interested in doing. We're always eager to find new collaborators. So if any of you feel like you're getting particularly interested in what I've been talking about, certainly let me know. I'd be happy to answer questions or, talk about different ideas and things we might be able to work on together in some way. But some of the ideas that occurred to us were taking a closer look at the characteristics of patients, for instance, who were positive for THC only, looking at their chief complaints and diagnoses and dispositions to kind of figure out what happened to them as part of their ED visit, and then also being able to look at this data, because one of the things we do with the EHR data, when we start with the hospital, we go back in time as far as we can. So we have many years of data in our system. Some of the hospitals go back to 2017, for instance, so being able to look at trends in THC positives over time could be an interesting analysis as well. And then one of the things that we have been able to do with NEDS is to influence with our results by sharing back with the hospitals and local legislators. We can impact specific hospital policy and even some statewide policy as well. So for instance, in California, there was a movement after we started working with some hospitals in Southern California, local advocates who used our results to work with state legislators and pass over the first legislation that required hospitals statewide to test for fentanyl. Maryland then used that legislation as a model to pass their own legislation, and so we now have the first data in Maryland from that required fentanyl testing. So that's an example of some of the policy work that we were able to do. And some other kinds of ideas we had relate to working to disseminate our information and put it out in a way that it can be used and reach people in a meaningful way. And so one of the ideas that we had was working with local hospital staff and other experts to create a harm reduction or resource toolkit that could be used by the hospital staff and the patients to kind of build a continuum of care so that help the patients find the other services and resources they may need once their emergent situations have been dealt with. We also want to encourage the physicians and staff who work within the hospitals to communicate directly with each other instead of just with us. So we had the idea of an ed stakeholder network as a tool for doing that. That would give them an opportunity to share their experiences in getting bugs from each other. We also have the interactive data dashboards that I mentioned, and you'll see there for each hospital there will be one that looks at the demographics. There'll be a couple that show trends over time, and we have one that looks at polysubstance exposure and things like that. I also want to make sure I take a moment to thank ONDCP, because ONDCP has been a great partner in working with us to support the launch of EDS and the piloting of our methodology and the development of our system. And so we have greatly appreciated being able to do that with them and share our results with them. We're also actively looking for funding and support and collaborators to work with to continue what we're doing and expand in some of these ways I mentioned. So again, if you have any questions or you'd like to talk with me further about any of this, I will be here for today. I'm happy to talk with you or even set up a meeting with the rest of the team as well. So here's some links that may be useful to you if you want to learn more about EDS or CESAR and the work we do. I have our homepage for EDS listed there again. I also have links to a couple of interviews we did recently. One is an interview that my colleagues and I did with the local TV network, who did a series of stories on the drug crisis in Maryland, and they featured EDS and the work we were doing as part of one of their stories. And we also recently were included in a new episode of the podcast Equal Dose. And so we're in that episode along with a colleague from the CDC, who did a very interesting interview as well about the data and work the CDC was doing. So I encourage you to watch that as well. I also want to mention, just at the end here, the CESAR Research Network. I mentioned it at the beginning of my comments. This research network is about 1,300 members in a virtual community. And if you're not a member already, which I know some of you are, because I recognize some names and faces here today, but the network is a tool that we use for releasing updates and new findings through EDS and other work we're doing at CESAR, but it's also a great place to go, again, to share information, ask questions. If you have a new article, you can share it with the network, and you'll find kindred spirits there. It's experts in not just toxicology, but also in drug policy and treatment and harm reduction and writing and journalism as well. So it's a great place to go to find ongoing discussions on a variety of different topics, and it's easy to sign up. There's a link on our homepage under items of interest. And you're also welcome to get in touch with me and my colleagues directly. I have my email there at the bottom, and as the co-I for EDS and Deputy Director of CESAR, and then I also have the email for Dr. Wish, the PI of the EDS system, and my colleague Amy Billen, who's co-I and project manager. So, thank you for your time.
Well, I wasn't supposed to come up here, but I need to tell a little story about Erin, and just, or at least, not so much a story, but to show you the impact. So I have an email from March 9th, 2006. Hi, Erin. Hope all is well with you. I am back in Oxford working on my dissertation. Things are well. In the fall, I may head to NDRI, was an NIH research center, with Bruce Johnson, who unfortunately has since passed, an incredible researcher, as a pre-doc fellow, but I'm still not sure. I was wondering if you had data on heroin initiation rates and chronic heroin use rates for Baltimore. NISDA data would be unhelpful. No offense to HHS. Has CESAR done any independent surveys of this, or do you know of any others? Please give Erin my best. Thank you. Thanks, Kevin. So we've been in touch for over 20 years, and I was the kid, bothering her while she was trying to do real work about different data that was out there. But my point of this, and you should have seen her response, so thorough and incredible, is this is an amazing underutilized resource that, if you've sort of been in this field for a long time, Amy, for example, knows about it, some others do. They do incredible work, but yes, NIH, NIDA, Jack, we love you, we love NIDA, we love everything. But with such a small team and such a small budget, the impact that they have, I have to say, they used to do, and they do a version of it now, but they had something every Friday, I think it was Friday, called the CESAR Fax. And it was a fax, F-A-X. I remember those. Everyone under 30 years old. What? It was a fax. We had a fax machine. And everybody in the field on Friday at 4 o'clock, wherever you were, would get a fax with one fact that was a data point to have. It was so interesting. We completely copied that, by the way. We have a Friday fact that comes on your email. That's one fact we copied. I have to say, imitation is the best form of flattery.
Absolutely.
And because they're just doing amazing work. So when Erin and Eric, people don't stay in a job for a year anymore, let alone over 25 years or more in these positions. When they reach out about the summit, it was just incredible. So please utilize this resource. Erin, we're so happy to have you here. Thank you.
Thank you.
Thanks for